Well, we have, it's a pleasure to introduce Nick, and I can let him say more, but one thing that this university has done a good job of is to make tutoring services available more to the students. And in particular, we've been fortunate enough for several semesters now to have upperclassmates in nursing that would be willing to tutor students in term 2 and term 3 and such. And so that's why Nick is here, and I'll let him talk with you about that process and what he's here for.
Alright, well, if you guys need tutoring in basically any of your term 1 classes, you can come find me. I have my email up here, and those are the hours that I'll be in Library 220. And if none of those times work for you guys, you can go ahead and send me an email and I'll set up a one-on-one time. I'm pretty flexible whenever I don't have class or anything else.
You'll be in term 2 then, right? You're in term 2, so schedule's a little different, but we figured it out, right?
Does anybody have any questions? Or?
So it looks like Sunday 4 to 7, Tuesday 6 to 8, that's 6 p.m. to 8 p.m., right?
Yeah, right.
Okay, and then not 7 a.m. And then Wednesday 7 to 10 in the morning.
And I can help with care plans too, or pretty much everything like that.
And if I've asked Nick if there's something that comes up repeatedly, like in this class that students are struggling with, or the concepts are more challenging, to let me know, because then we can hit them again in class and just connect that way as well. So sometimes it's a common theme that we're seeing that students are struggling with a particular topic, and we can address those things more specifically together as a group. Use tutoring. Don't wait till you do that on an exam. If you're, it doesn't matter. You're all good students, but this is going to be different for you when you start taking these kinds of tests. Trust me, right? This is not like taking tests outside of this. These tests are very different. It's a lot of synthesis and application. So, a lot of times it's just having a conversation to better understand a concept. And so, I think that I'm going to get him status in the class as a teaching assistant so that he has access to the slides and the other content that we're talking about so that he can hold them up as well. So I'm going to work on that first part of next week if I can. Any comments or questions? Can everybody see the email address? Very good. Thanks very much.
Thanks.
Appreciate it. Okay. It's warm in here. Yeah. It's hot in here. How are you doing? How's it going? It's going well? Have you had any quizzes yet? No. No quizzes yet, okay. No tests yet. Yes. Is it Rebecca? No? Heather. I couldn't quite see from here. It's at a bad angle for me. Heather.
The content on the exam.
Content on the exam. Okay.
This is chapter 1, the syllabus. We don't go to chapter 1.
Are you talking quiz or exam?
Exam.
Okay. Remember some chapters are review chapters for you? Like chapter 1 gets you set up to understanding cells and those types of processes again. In that case, for chapter 1, I may not specifically pull a question out of there, but it's concepts that might help you to understand chapters 2, 3, 4 a little bit better. So, if you're struggling with something there, you might go back to chapter 1 and look at that. It might help you to get a better foundation for it.
Like chapter 5 and 6.
So you'll be tested on that. And how I handle chapters that have worksheets attached. The concepts on the worksheets are your study guide for those 2 chapters. So I pulled out key things that on the worksheet. So conceptually, I may write a different question around that concept, but those are the concepts that you need to grasp. Genetics is a very detailed field, and we're learning more about that all the time, but you have to have a basic understanding of it because many of our diseases evolve around genetic mutations and such that we're discovering, the Genome Project, and it's just opened up a huge array of new things for us to think about. So nursing and health providers in general have to understand a little bit about what we're talking about, okay? Did that answer your question? Is that fair? Okay. All right. The test a week from today is multiple choice, multiple choice, and I haven't decided if I'm going to write anything like, have you define a term. I don't know if I'm going to do that as a write-in question yet or not, but I'll make that decision next week when I actually write the test. Okay? Yes, Rachel.
Is it like filling up with what's on the PowerPoint, or is it on the PowerPoint in the book? Would that be on it too?
It's not solely off of the PowerPoints, okay? You have to read your chapters, and the way you read your chapters, use the PowerPoints as a guide to get through those concepts in the book. For example, the next, one exception to that, the next chapter that we're going to talk about, I'm not going to test you from the book. I'm going to test you how I talk about that chapter. And I will make that clear again when I open that up, because that's a dense chapter. I find it's kind of an awkward chapter to get through, and so I pulled it out conceptually in a way that I think about it, and the way it's done in other literature bodies out there, and I think it's more understandable. And if it doesn't work, let me know, but I think that'll help you understand that material more specifically. So, you know, there are times when I will ask you a question on the chapter, so, but it's based on the conceptual pieces that we talk about in class. Okay, make sense? Because we can't cover it all in class. Yeah. Okay, let's see what else. Let's see, we're going to finish chapter 3 today. We'll start chapter 4. Remember, the worksheet is due in the Dropbox by the 30th, and the key will pop up and be open for you at that, you know, Wednesday morning, which is the 30th. Isn't Wednesday the 30th, I think? Okay. So that it'll be there for you for a couple of days before the test. Monday we'll finish up what we didn't get to today, and we'll start neoplasia, cancer. We'll talk about cancer. And then we already mentioned about the exam. Anything else?
Quick question.
Yes,
Okay.
Luke.
So on the exam, you said multiple choice. You can like check all that apply. Is
I
that
do
what you
mean
by
that. Check
Okay.
all that apply. Yeah.
Okay.
Yep. There's, on the licensure exam, you'll have numerous types of questions, multiples, you'll have click and drop, you'll have point and pick, you'll have fill in the blanks, you'll have calculations, you'll have multiple choice, you'll have drag and drops, you'll have all kinds of things. So you'll see those things built into the types of questions we write in this program too.
Are those all or nothing questions?
Are they all or nothing questions for points? Great question. Sometimes yes, sometimes no.
Okay.
Most of the time in this class, they will be partial credit. As you move up the ranks in the different terms, it may be all or none. Okay? Yep. Yes. Because you're still trying to learn the process of how we test. So I'm a little bit easier that way in terms of giving you partial credit this semester. I won't be necessarily when you get to term 3. I'll be less prone to do that. Okay? Anything else? Good questions. Okay, yeah.
Is the test gonna be like your quiz? Sorry, I forgot my name today. It's Kelsey.
Kelsey.
Is it gonna be like where you can't go back?
I will not, the test is not one question per page, and it's not where you can't go back on this first test, or the quiz either. I don't think I set that up that way. Okay, I'll double check that. There will be times when it is that way. The other thing I won't do, and I'll come right back to you, is I'm not going to allow you to see the answers. You'll get your test results, but you won't be able to see the answers. Okay, if you want to see the full test answers, you can come and see me in my office, and we'll pop it up. What I do is look at the test analysis. I look at the stats, and I look at how the test questions performed, how you performed. If I have a question where 90% of you got it wrong, then that's either the question or it's the content that you didn't get. And so I reevaluate that, and sometimes I will just give that point back, or, you know, I work that out, and then I'll talk about it in class so you do get it. I'll pull that question up and say, this is a question you struggled with, let's talk about that so you do understand that, okay? So that's kind of how I handle that. Yeah. It's, the quiz is 10 points, and I'm trying to remember if it's 8 questions or 9 questions. I think usually for the multiples, they're worth more than 1 point. So it's 10 points. It's either 8 or 10, 8 or 9 questions. I think I've written. The exam is 50 points, and I don't know if that will be. It'll be somewhere between 45 and 49 questions usually. Okay. And you have a 50-minute window to take your tests, and you have to be done. Okay. So you need to, if you're not a good test taker, not a speedy test taker, and it isn't about speed, but you do have to time yourself as you get through these. The NCLEX exam that you take when you graduate is timed, and so you'll be practicing not only how to take tests and just demonstrate your knowledge, but also how you can, there's 2 different things. There's content knowledge and test skill, and now you're going to kind of learn how to bring those together. You can be content rich, but not know how to take an exam very well, and those skills come with practice. Okay, you'll get more proficient with that as you go. Any other questions? Great questions. Love questions. All right. So, we have to finish up talking about inflammation, and we'll be talking about wound healing and such shortly. But one of the things we talked about was the white blood cell response when you have an injury. And the next piece that we want to think about is the acute phase response. And this term is used to describe the systemic effects during an acute injury, okay? During acute or chronic inflammation. And that describes, what's happening to more than just at the local site. Now we're looking at the whole body, okay? And how many of you have been sick before where you've had an acute inflammation and you get a fever and you have general malaise and all those, your white cell counts, you go to the doctor and they're elevated, that sort of thing. So those are some things that we're going to talk about. And the acute phase response, it begins hours or days after the onset of inflammation or a severe infection. And it includes a couple different things. It includes it switches to burning your muscles, so it switches to skeletal muscle metabolism, that's breaking down of your proteins for energy, okay? And it also includes, if the person has been hospitalized for a period of time, it might mean if you have enough catabolism happen that they end up with a negative nitrogen balance, okay? I mean, they don't have enough nutrients to feed what's happening, and now all of a sudden they have a negative nitrogen balance, and that's not a good thing. And we can do some diagnostic tests to look at that, and we can actually see muscle wasting happening. The other is that with an acute inflammation, one of the tests that is elevated is erythrocyte sedimentation rate. That's a lab test. Erythrocyte. We call it SED rate. It's a marker of inflammation. It doesn't tell us where or how bad, but it's bad enough where that goes up. The erythrocyte, and it's how the erythrocytes settle out when they spin them down. And you can look that up in your diagnostic book. The other piece is with overwhelming inflammation or acute inflammation, like after surgery, big surgeries, or after an acute infection, you may see the white blood cell counts elevated, right? They may go up. And then we look at the differential count to see, okay, is it neutrophils that are high? Is it lymphocytes? It helps us to begin to say, okay, it's viral, or it's likely bacterial, or it's parasitic, because the eosinophils are now elevated, and so forth. The other piece is a person may experience a fever if it's significant enough. And also, along with that fever, the heart rate goes up. Okay, those are some of the systemic types of things that you may see in patients. The other piece here is C-reactive protein, and the liver makes both fibrinogen and C-reactive protein. And C-reactive protein is important. It binds to the surface of microbes, for example, and it targets them for destruction. So when you have an infection or an invasion of microorganisms, C-reactive protein becomes very important. It is also a marker of inflammation, and let me just elaborate on it for one more statement. When you have an overwhelming inflammation, C-reactive protein elevates. During an acute myocardial infarction, we test for C-reactive protein, and in patients, it's a marker now of inflammation like with atherosclerosis, and don't write this down right now, but we have discovered with atherosclerosis, there's an inflammatory change that happens in the blood vessels, and for some people, we notice their C-reactive proteins are elevated, and it's one of those risk factors that we're looking for now in cardiac disease. So it's kind of interesting. You'll hear more about that as we go through. The other piece along with this is when someone does then have a fever and such, a lot of times, how do you feel? How do you feel when you have a fever, when you're sick?
Tired.
Tired. General malaise, we call that, right? Just fatigue. No energy. The systemic inflammatory response, we call this very specific things. We're going to spend a lot of time talking about this, a little bit this semester, a lot in term 3. With sepsis now and such, we've learned a lot about that process, and we now have best practices in how to treat it when someone comes in with an infection. And we will cover this very in detail in term 3 in high acuity, and so stay tuned for that in another couple semesters. Okay, let's just spend a few minutes on this slide here. There's some things that we need to be thinking about in fever. It's part of the acute phase response. And where's your thermal regulatory center? Look at this one. Hypothalamus, right? That's an important piece. And if you look at this, one of the things that happens when someone has an infection or they're having a fever with a very significant acute inflammatory change is there's prostaglandins and other things that are released, and it actually communicates with the hypothalamus, and we change our set point. So the set point, our core temperature is usually 98.6, 97.7. You know, it's kind of right around in that area. And when someone fevers, that set point is elevated. So maybe when you have a fever, now the set point is 101. How many of you have actually had a fever? Do you remember how that felt? What sorts of things did you experience?
Like, you're sweating, but then you get really cold.
Okay, so you start out, you're sweaty, and then you get
And you're
cold,
like really, really hot.
and then there's a flushing
But
time.
then you're really cold. Yeah.
Yep. And so initially then as that temperature, the body is trying to raise your temperature, okay? What happens during that time is vasoconstriction because it's conserving all that energy to the core. And along with that, vasoconstriction, you start to shiver. What does shivering do? It raises your body temperature, it generates energy and such, right? And then along with that, what's piloerection? It's a funny little word. Yeah, it's goose flesh, right? Have any of you experienced that when you've had that go on? And while that's going on, that's increasing your metabolism, so that's important. And then once that fever rises now, eventually that fever starts to come down, and what happens? You get vasodilation, that's when you get that flushing, and you get really hot and pink, and you take those covers now and you throw them off, and you're no longer cold, okay? You start to sweat. So that's kind of that cycle. You have to know the purposes of a fever. There's a reason why we fever, okay? And the purpose is, during an infection, it's important because small increases in temperature are going to tell us there's an infection, that's one thing. But the other things is it boosts your immune system cells. It communicates, it tells your immune system cells that they need to get revved up. And it also, there are the microorganisms that invade, many of them which are bacteria, they do not function well in a high temperature environment. And so that's one of the things that happens there is it raises that temperature. Microbes don't like to grow in a higher temperature environment, so it reduces the growth of invaders. So those are some important pieces. Okay, I'm going to give you some important tips, and I haven't done this in a while, so I'm going to talk about this, and I will eventually do this slide, but I didn't have time to do it. Okay, you're going to be dealing with patients who go to surgery. And many of your patients are going to have what's called a post-op fever, post-operative fever. And our job is to know, well, why are they having a fever? Is it because of infection? Is it because of something else that's going on? Between 40 and 50% of surgical patients develop a post-op fever, depending on the type of surgery that they have, okay? But only a small percentage of those are because of an actual infection. So as nurses, you need to know why on the first day after surgery that person has a low-grade fever. It's not because of infection, but it's for something else. And so I'm going to give you some tips to help you figure that out. So I'm going to give you an acronym. It's the 5 W's. The first one is wind. And post-op days 1 to 2. One of the things, I want you to think wind. If someone develops, let's say they did not come in with an infection, they had major surgery, now you're caring for them the day after surgery, and they have a temperature of 100. Okay? Why the heck do they have a temperature of 100? Think wind. And when you think wind, what organ do you think of? Lungs, okay? So it might be the lungs. So i.e., did they aspirated surgery? Do they have atelectasis? What's atelectasis? Collapse of the alveoli, which is a common thing we see after surgery because of numerous things, and we'll talk more about that when we get to respiratory. So that's the one thing to think about. The next one is water. And between post-op days 3 and 5, if the person develops 101 temperature, I'm going to start thinking water. And what system would maybe need water? not a good enough tip. Kidneys. Okay, and this would be in somebody, for example, who has a Foley catheter, an indwelling Foley catheter. Now I'm worried that they have a potential infection here, so I'm gonna look at that urine. Is it cloudy? Is it stinky? It doesn't have sediment in it. You know, what's going on with that? The other then is, this is kind of a weird one, but walking. And another way to say that is vein or wane, is how some people say it. And that is, this is usually post-op days 4 to 6. And do they have a deep vein thrombosis or a pulmonary embolism? That's something I would start thinking about. The next one is wound. And this is usually between days 5 and 7. Can be overlaps with this one, so I would be thinking this too. But now I'm looking at surgical site infection. So listen to me when I say, if you have a patient, first day post-op, and they have a temperature, you're not going to say, wound infection. No. Unless they came in with an infection, it's going to be something else. But 5 or 6 or 7 days afterwards, I'm going to start thinking wound infection. And so you're looking at that wound now. Is there drainage? Is it increasing in redness? Is there increasing pain instead of lessening pain, and so forth? Okay? And then the other is kind of weird too, wonder drugs. And this is like day 7 plus. And these are induced because of drug effects. And it can also be now infections related to your IV lines, your central venous access devices, reaction to blood products. I'm sorry, it's kind of way down here, wonder drugs. So it could be blood products, drugs, and there are some drugs out there that do have an impact on the temperature. Drugs, and now I'm thinking, is the IV site, intravenous sites, or central venous catheters, are they becoming infected? So these are some things to think about when you start doing your clinicals now. These are great for your care plans. Okay. You're starting to talk about care plans, right? Mm-hmm. That's a little sidebar on how to figure out post-op fever. And you would reference, if you put that in, something like, okay, post-op day 1, I'd be starting to think about lungs, do they have atelectasis? You'd be listening to the lungs frequently and so forth, and you can reference this class, in terms of your learning is where you got that. Okay, there are 5 stages of fever, and not everybody experiences all of these necessarily in exactly this order. Okay, so again, go ahead and take a look at this. One of the key things I want you to get is that when you have a fever, you switch from utilizing glucose as energy as your primary fuel source to using protein. That's why that catabolism happens, because bacteria need glucose to proliferate. So that's one of the other benefits of a fever. We switch from glucose to protein use. And now bacterial growth is inhibited. Does that make sense to you? Mm-hmm. A really good benefit of that. All right, this is the other thing you have to know, ladies and gentlemen. This is a very important slide. You have to be able to predict, as the temperature is going up, whether you use Celsius or centigrade scale or Fahrenheit, okay, what you could predict to see that temperature or the heart rate to go up in. So for every 1 degree centigrade, your heart rate goes up 15. So if you have a baseline of 80 before they went to surgery, and now they have a temperature, again, look at how high that temperature is. You can predict where that heart rate is because of that fever here. And so what happens when your heart rate goes up? What does that do to your body? Its demands. It increases the demand on your body, doesn't it? The heart muscle has to work harder. So that gets at the question of, do I treat that fever or do I not treat that fever? And that's a real controversial issue, and we have learned that low-grade fevers are very beneficial, so we don't routinely treat a low-grade fever anymore. We used to all the time. We don't, because if they're tolerating it well, they don't have a cardiac history, we're going to let them get through that fever process, right? However, especially if it's, from atelectasis. If they have an infection, we're certainly going to get them on antibiotics and such. What I mean by treating a fever is like trying to reduce the fever, like with Tylenol. Okay, that's what I'm talking about in terms of treating the fever, not the reason for the fever, but the fever. And so you need to understand that, and this is going to be a good test question, and you need to know this for practice. This is what you're going to see in practice happening to your patients. The other question then is, all right, if I have 101 temperature in somebody who has ischemic heart disease, they've had a heart attack, now they're in for an infection, I may choose to treat that 101 because I don't want to tax that heart any further, right? So there's got to be a good picture that you're looking at here, putting it all together to make that decision. Kids, you'll learn when you take peds, they actually can tolerate pretty high temperatures pretty well. They can tolerate 103, 104 temperatures pretty well, better than you can, right? But when a temperature starts getting up to 102, that's when you're going to see us really probably looking at, in adults at least, trying to reduce that fever to some extent. Give them some time, we'll make them more comfortable. Because if they're acutely ill already in the hospital, this is going to tax them even further. Make sense? Okay, very good. All right, true or false? Body temperature is controlled through negative feedback loops. Got it. Good job. Okay. Just a few things about chronic inflammation and the differences. Acute inflammation happens immediately after an injury, after surgery, which is an injury to your body tissue, your vascular tissue. Chronic inflammation comes later. And one of the things that's different here is now, instead of lots of neutrophils at the site of inflammation, now we're seeing more macrophages, right? So you're going to see a higher, so if I were to do a WBC differential, I'd see a lot more macrophages on that in terms of numbers than I would see neutrophils. They're very important for a lot of different reasons. So chronic inflammation is characterized by macrophages being present at that site. So again, you'll see those on the white cell count if we're looking at that. And also lymphocyte presence as well. And those are markers of the immune system. And so they're very important relative to that part. Okay. All right. If you get a paper cut, epithelial tissue will be replaced with connective tissue. Paper cut is very minor. Your body has the ability to heal itself really well. Anybody ever have a little minor cut? Do you get a scar tissue from, or a scar from that? No. So what's the answer to this question? And we'll talk about that. We'll talk about repair of tissue. Any questions about that? Some important sides there. It'll help you understand what you're seeing in the clinical site. You'll understand the physiology of what's happening when you start looking through some of this. I will not test you on the chapter. For this chapter, I will test you on the PowerPoint slides and our discussion on that. Okay, so this is a different kind of chapter for us. And I don't think I'm going to be able to go forward with my mouse, am I? Okay. So we're going to talk about wound healing, regeneration and repair. There's two different ways in which we heal. One is with regeneration, and the other one is a process called repair. And so let's talk about regeneration. And in some of the literature, you will hear two different terms used. They mean the same thing, basically. Resolution, regeneration. That's what we're talking about here. Okay. The most favorable outcome after tissue injury is that we want it to return back to its normal structure. We want it to be the same strength. We want it to be the same appearance and so forth, right? I mean, that's ideal. One of the things we do know is that if the injury is significant enough, it can take as long as 1 to 2 years for that process, that repair process to happen. But we're going to talk about regeneration first. And if you think about the capacity to regenerate, we have to think about not all of our cells can regenerate, all right, if they're injured, but a lot of them can. And so there are 3 different types. And these have, what we're talking about here, the cells and tissues that can regenerate are ones that are continuously dividing. They can go through mitotic division, so they can replace themselves. The labile cells, which are line your skin, they're your skin, which is your epithelial cells. They cover you, and they also line your organs. They line your esophagus. They line the inside of your intestines. Those continuously divide and replace themselves throughout your lifetime. So when you have a minor injury there, and it heals, they go back to their original state, right? If there's not a lot of tissue loss and the injury's not severe. So this is cells in these areas that do a pretty good job with minimal injury of getting back to their original state. So they go through resolution pretty effectively. Stable cells constitute what's called a parenchyma of your solid organs, like your liver, like your kidneys, and I can write that term down. You're going to see it in your charts. You're going to see it in surgical reports. Half of getting this stuff is just learning the terms, isn't it? Right. Driving me crazy. So again, these are, so one of the things with the stable tissues then is it includes your smooth muscle cells, okay, and fibroblasts. And the fibroblasts are needed for wound healing, and so that's some of what we're talking about there. Permanent tissues and cells, these are cells that can't undergo mitotic division, so they can't proliferate. That means they can't replace themselves. An example of that is if you have a heart attack. The myofibrils of the heart they don't go through mitotic division. When dead is dead, they can't replace themselves like your skin can. Okay? Your nerve tissue, the same thing, right? Your skeletal muscle tissue, same thing. And so, again, permanent tissues that's another type of thing that you're going to want to pay attention to there as well. Okay, so resolution is the goal. And what makes it impossible to happen? If you really damage that skin and you cut out a huge chunk off your thigh or your arm or your chest, you're talking a different kind of repair, different kind of healing process. In tissues that can't regenerate, like right here, right, the permanent tissues. If you get an infection, you can't heal until you get rid of the infection, like in an abscess or contamination. Or if there's excessive fibrin. Fibrin is very dense. It's part of the mesh clot, but it also contributes to adhesion formation, which are scar tissues, like internally if people have big surgeries, a lot of times they get fibrous bands, we call them adhesions. Adhesions, that kind of scar tissue can wrap itself around organs. It can cause problems with movement and lots of pain and things like that. And it can impair the healing process. Okay. Right, so the other piece, so we've got that first piece that we talked about, regeneration and resolution, same thing. Now repair. With repair, there's more tissue loss, there's significant tissue loss. So it's not a nice, clean little surgical cut where the edges come really nice together and we suture them together. It's not a nice little clean paper cut, but instead it might be a decubitus ulcer. How many of you have heard of those and are older folks in long-term care with diabetes? They have gangrene. We got to get rid of the gangrenous tissue first before they can go through this process. So eventually, though, in that process, they're going to end up with some scar tissue. Once that tissue repairs, you end up with a scar. So repair is the replacement of destroyed tissue, eventually with scar tissue. And scar tissue is comprised of collagen, okay? Collagen is a protein. All right. How are we doing so far? Is this making some sense to you? Mm-hmm. And why do you need to know this anyway? Why do you think we're talking about how wounds heal? Anybody want to take a guess? Yeah.
Like if there's a patient whose wound isn't healing, this would help us figure out like why it's not healing, what we can do to help it heal.
Yep. And how we treat it is very different than one that is going through resolution, right? So a lot more protection, different kinds of dressings. It might be antibiotics. It might be different kinds of solutions we're using to impregnating that wound to get it to heal. Yes. So it helps us to know, is it normal? Are they going to be longer term stay now? Yes, all of that kind of stuff. Okay, so wound healing then. In general, there's a couple of things. The wound healing involves 3 processes. Okay, we talked about resolution and then repair. That's one thing, 2 different styles. But in both of them, there's 3 things that have to happen. The wound has to fill in with new cells. It has to seal itself, and it has to shrink, contract. All right? So, let's go back to an incision. Here's an incision that's made either through paper cut or surgical. With the paper cut, it closes off itself. You get filling in with the wound very quickly. Within a day, it's already close together. Those edges are really close. And within 2 days, you hardly notice it. I mean, you know what I'm saying? It's really quick. It fills in very carefully, and you can't even see, it grows in really well, and there's no scar. I mean, the scar is underneath maybe, but you see no scar on the top with that type of thing. When wounds are well approximated, that means that the edges come together really nicely. And in surgical cases, we do it, how do we bind those wounds together from after surgery? How do we hold those? Staples, stitches, Steri-strips, glues, okay? Underneath, inside, it's retention sutures that dissolve over time. So those are some ways to do that. And with a paper cut at home or minor injury, use a Band-Aid. Don't you put a little Steri-strip on there or something, or nothing. You may not need anything. But those wounds that are, where the edges are really nice together, we call that primary intention healing. Wounds that are open, that are big like that, and have to fill in from the base and edges and come together, that's secondary intention healing. This terminology that you'll see out there. Okay, so let's see. Healing then. Again, primary and secondary intention, I just mentioned that. In secondary intention, oftentimes it is the case that there's infection or dead denatured tissue there that has to be removed first. The wound needs to go through a repair process and before it's closed, or we may even have to take a piece of skin from one area and graft over that area so it heals more effectively. One of the things that I think is interesting at best when you're looking at tissue that's been repaired, it will not regain 100% of its strength, and we call that tensile strength. Does anybody know what tensile strength means? If I were to try and give it a good pull, it won't open. 100% tensile strength, it's nice and strong. But in something that has very little tensile strength, it's easy to rip apart, okay? So in wounds that go through repair, they're never going to go back to their original state, so you end up with a scar. Tensile strength can get up to 80%, but it's never going to be 100%, okay? Never going to be 100%. And again, I think this, we've kind of talked about some of this already. Secondary intention healing, then you can see in this case, there's a fair amount of tissue losses. One of the things that happens in repair is that the wound has to fill in, and there's a lot of different cellular changes that happen to make that happen. Fibroblasts come to the area. Fibroblasts, by the way, deposit collagen, and collagen is protein, and that helps the wound fill in, and we'll talk more about that specifically. But you can see how open this is here, and it's actually, this is there's no skin, there's no skin here, it's very open. And now you'll see these cells lining up here, it starts to fill in at the wound base, and eventually look at how now the wound is kind of, remember we said it has to fill in and then it has to shrink or contract. You can see how that's contracting, and now there's a scar that's forming over that. And this scar can continuously change now from months to years, depending on how extensive that wound was. Anything else I want to mention about that? I don't think so. Okay, so again, wound healing, whether it is from resolution or repair, goes through these processes. Inflammation, we've talked about. An injury is an injury, right? You're going to stimulate that inflammatory response because you've reached your barriers, right? And then proliferation means cells are going to replicate, those that can do so, and new tissue begins to form. Replace the old tissue. And then a remodeling and maturing of that scar that goes on. So again, this is not cast in stone. This gives you ideas about length of time. So as you're observing those surgical wounds or those open wounds, you get an idea of what you're thinking about, how long you would expect that inflammation to occur. That's that redness and heat and swelling and all of that, and so forth. So again, the first couple of days, the inflammatory response is in full gear here. The clot has formed, and it's beginning to, white cells come into the area, nutrients come in to help that area heal. That's very important. Neutrophils, platelets, all of those pieces. I've kind of put it on a grid here for you a little bit. So with primary and secondary intention, they still go through different phases. This just takes longer. So within that first 24 hours, remember you get vasoconstriction, it stops the bleeding, then it vasodilates. There's a clot that forms over that area in the capillaries that were ruptured. The cells begin to proliferate, that means duplicate, fill in, close it off. Again, in this case, there won't be a scar left. In this case, it's going to take a little bit longer, and there will be a scar that's going to change over months to years. So then that phase 2, proliferation and new tissue, again, starts 3 to 4 days after the injury. This is where it's beginning to seal off now. One of the things that's important here is when you have new wounds, you have to protect them as nurses, so we use different types of dressings. What's going on in practice right now is with complex wounds, decubitus ulcers, wounds that heal by secondary intention, it's a whole art and in terms of knowing how to dress those wounds, and we now have wound specialists in our hospitals that come and consult with you as nurses about what's the best treatment choice, dressing choice for that particular type of wound. It used to be we had 5 choices. Now there's dozens, and each has its own specific purpose. So you will learn a lot about dressings, and you'll learn some of that in your skills and assessment. You'll learn it as you work with surgical patients and patients with wounds, but it is a real art today. So we need to protect these wounds, and there's different ways we can do that. So new tissue is beginning to form, and the characteristics, these are important here, is because macrophages that are now at that area call out the fibroblasts. Fibroblasts begin to lay down collagen, which is new protein. We also see epithelialization, and that is laying down new epithelial cells. The other cool thing that happens then is you'll see, we call it angiogenesis. What does that term mean? Angio means blood vessels. Genesis, new, right? So the formation of new blood vessels. And so it's really cool when you see that in these big wounds that are open like that, you see all this new beefy granulation tissue, new capillaries form, and you can literally see the capillary buds. They're so cool. And when you see that stuff, it's like, oh, this is really healing. If you don't see that happening, the wound is often not in a good stage of healing. What about the macrophages again? These are some of the things that those macrophages do. Angiogenesis factors, what you need to know about that. They secrete chemicals that cause new blood vessels to form, new capillaries. This little thing here, matrix metalloproteinases. Oh, God. Where do you come up with this stuff? What they do is, what's important here is they take and degrade any excess collagen. Remember, we have to put the brakes on things. They'll degrade that excess collagen and fibrin that needs to be dissolved. So they will help in that final stage of repair. This is cool. I know it looks gross to you, but this person, this is what it looked like here. There was an infection there. There's necrotic tissue sitting on top of this. And we treated with antibiotics and needed to go to surgery to cut out that dead tissue. We'll do this a lot with burns. And you can see, what does this look like to you? Looks like jelly? Yeah, yeah. It's beefy red, right? This is awesome. This is a healthy wound base. Because what happens if I were to actually look at this now, new capillaries will begin to form, and you can see these little things poking up that look like little red dots on the base of the wound. Those are new capillaries. And then over time, you'll begin to see this fill in from the edges and the base. Now this, because of the extensive nature of that, likely will need a graft. But there are times when we let the wound fill in as much as it can and see how it goes, and then With some wounds, then ultimately, eventually, we'll need to maybe graft them with new skin from another site. And is this primary or secondary intention healing? Yep. Yep. So what should you be concerned about during wound healing, particularly, and by the way, granulation tissue is this kind of thing where you see it starting to fill in and you see those capillary buds. That's all new tissue. What do you want to do? What's the primary goal? One word. You want it to heal, and how do we do that? Protect it. We do that with dressings and other things to protect that site. We don't want to contaminate it. We don't want it to get infected. We protect it. So there's numerous ways that we do that. Different types of dressing approaches to help heal it and protect it. Keeping wounds moist. It used to be that we thought, you don't want any moisture at the wound bed because then it attracts organism growth and you're going to get infections. Well, now we know that you need to keep moisture at the wound base so all those cells can do what they need to do. But there's a fine line between too moist and, not enough. So again, that you'll see those balances made and choices made out in practice. Important fibroblasts. We've already talked about their role with collagen. Very important in laying down that new collagen and other connective tissue proteins. Collagen is probably the most abundant protein that you have in your body. And it helps create a scaffolding, I call it. All the neighboring cells start to hold together. So that's very important, that those things start to adhere together and they start building a scaffold underneath there of new tissue. And it also, the myofibroblasts are very specialized. They actually help anchor themselves and assist with that scaffolding as well. And they're involved in that wound contraction. Yes?
Is that like, for like a burn victim, you know how their skin gets really tight?
Yes.
Is that what is making it so tight?
That's a really good question. What happens in second and third degree burns, which will eventually be grafted, is that there's tons of scar tissue, and scar tissue will shrink, especially when there's that much of it. And so burn victims will have special appliances made. Like let's say the burn was on the face. They'll have special appliances made if the burn was around the mouth and in this area, like a mask that stretch that scar tissue and prevent keloid tissue from forming. There was one, I worked burns for a long time, there was one gentleman who got severely burned and he had to wear, when he wasn't eating, a special device in the mouth to keep the mouth from closing and developing so much scar tissue that he couldn't eat. And he was supposed to wear that. He didn't. He came to the burn clinic and his mouth was like that. And he had so much scar tissue, it was impossible, and so it shrunk. So in those cases, when it's so severe, there's appliances that help stretch it to prevent it from contracting and becoming disfiguring and creating a situation where the patient can't function. So that's a really good question.
Does that happen pretty quickly?
Over a long period of time, yeah. Phase 3 then, remodeling and maturation. That's that scar tissue formation again then. Within 2 to 3 weeks. Let me grab that for you.
Thank you.
About 2 to 3 weeks after this phase has started, scar tissue has gained maybe about 2/3 of its eventual strength. So it happens reasonably quickly. And again, just showing you how that primary and secondary intention and kind of putting that here up for you again. I'm just going to do one more slide here. There's things that can cause and impair wound healing, and what's going to happen with you is you're going to be looking at your patients and trying to identify those risk factors that put them at risk for being able to heal. One good example is ischemia. You know, if you don't have good blood flow to an area, it's going to be very hard for those nutrients, that oxygen, those cells, the healing process is going to be impaired quite significantly. So that's something that we need to pay attention to. If a wound has excessive bleeding, it creates a mechanical barrier for oxygen diffusion. Okay, so excessive bleeding can impair healing. If someone has too low blood volume, again here, that it's going to impair the inflammatory process altogether, and that's going to cause vessel constriction and create problems with wound healing as well. So, and we'll kind of come back to this on Monday. Okay? So, I hope you have an awesome weekend. Your brains feel packed? Yeah? Is it, if you're struggling with anything that we're talking about, let me know. I've had some good questions, both by email and, in my office and for class and such, so just don't hesitate to ask.